Welcome, Dr. Michelassi. Dr. Fabrizio Michelassi is the Surgeon-in-Chief at New York-Presbyterian at Weill Cornell Medical Center, where he is also the Chief of Surgery at the Weill Cornell Medical School at New York-Presbyterian. If I got that all correct, it's my alma mater, but the name has changed since I finished training there. And very importantly, Fabrizio is one of my colleagues on the Board of Regents at the American College of Surgeons. Welcome, Fabrizio.
Thank you very much for having me.
Well, Dr. Michelassi, you have been near and dear to our hearts and thoughts and prayers for months on the Board of Regents and with the Communications Committee, because you really were ground zero in the United States and still the biggest hotspot in the United States for sure. We're all rooting for you through all of this, and we now want to learn from you now that things are on the downslope. So if you don't mind, I'd like to start out by asking you a little bit about what you think was done well and you would do again, and what you think you might do a little bit differently in the preparation for the surge. Granted, you didn't have nearly the preparation other places did.
Well, Steve, first of all, thank you for having me. And thank you, Steve, and the many, many colleagues through the United States who sent many messages of comfort and support over the past 2 months. You're right. We're really in the eye of the cyclone here in March and April, and to a certain extent even now, but it feels much better now than at the end of March, beginning of April. Just to give you an idea, I work at New York-Presbyterian Hospital, which is an enterprise of 10 different hospitals. One is a psychiatric unit, but the other 9 are regular hospitals with medical surgical beds. And we have about 4,000 beds throughout the system. And at a certain point, at the peak, April 12th, we had some 2,700 COVID positive patients. And I say 4,000 hospital, but if you eliminate the bassinets for neonates, if you eliminate the psychiatric hospital, etc., we really had almost 100% of the adult medicine beds completely occupied by COVID positive patients. Now at Cornell, at Weill Cornell, where I work on the Upper East Side, our hospital has about 860 adult beds with 110 ICU beds. And at the beginning of March, we had a handful of COVID positive patients, but by April 12th, again at the peak, we had more than 500 COVID positive patients, half of them in ICUs ventilated. So you can imagine that over those 4 weeks from mid-March to mid-April, we had to really flex up rather quickly, and a lot of decisions were made fast. And fortunately, I have to say they were all correct and on the dot. First of all, we had to create capacity. And like everybody else in the country, we did that by stopping elective surgeries by March 15th and less urgent cases by March 27th. We also had to work at expanding our ICU capacity from a baseline of 110 beds, as I mentioned, to almost 290 beds. And we ended up occupying 230 of those. This required converting operating rooms, recovery rooms in ICU. Not only that, but we had to deploy physicians. I was asked to be co-chair of a group here at Weill Cornell for the physician organization to deploy physicians and staffs. And by the end, we deployed some 330 physicians and staff to emergency room, to ICUs, to hospital medicine, to telemedicine, and so forth. Other thing that we did right was the establishment of a committee for the safety of surgeons and staff in the OR and in the procedure units. 3 operating rooms were equipped right away with ante rooms. There were changes made for positive and negative pressures. We provided equipment to evacuate the plume developed by the use of energy devices and the pneumoperitoneum during laparoscopic surgery. We also created protocols with nice visuals for appropriate donning and doffing of PPE and instructor surgeons and staff. Other things that we did, was that within the Department of Surgery, we had a senior surgeon. We elected a senior surgeon to vet all cases booked to make sure that they indeed were urgent, and that alternative therapies had been discussed before, with the index surgeons and the patients prior to booking these cases. Within the Department of Surgery, we categorized the faculty as indispensable for the activities of the Department of Surgery versus deployable. The indispensable, obviously, are the ones on call for trauma. Indispensables who are intensivists that obviously took care of the ICUs. The deployable faculty, on the other hand, were ready to be deployed. And some were deployed to the emergency room, some to the other ICUs, some were deployed to telemedicine. Some faculty, they were never called to be deployed, but they wanted to be part of this response to the crisis. So we came up with innovative ideas of how to use them. I remember, for instance, several faculties who, because of the no visitor policy, came up with the idea of rounding with the ICU teams every day on all the patients that we had, and then spending the afternoon reaching out daily to the families to give an update on the conditions of their loved ones in the ICU. For the educational thing, we moved to all the educational activities to a Zoom platform. We had a lot of speakers talking about different aspects of the pandemic. And talking about the Zoom platform, let me not forget telemedicine. There was a huge jump in telemedicine as a way to continue to connect with our patients, and in order to deliver the care we could without having them come into our clinics, without having them obviously facing the possibility of coming into a COVID positive intense equipment hospital. The challenges were very common to many other hospitals. We had challenges in securing enough PPEs, especially N95 masks and shields at the very beginning of the pandemic, and also the testing. At the beginning was difficult. We had to reuse N95s, we had to limit the testing that we were doing, and then finally with increased capacity, we were able to test all patients admitted to the hospital, all healthcare providers, and at that point, making decisions more based on the positivity of the test rather than the symptoms. But it was an impressive surge from the beginning of March, say the first week of March to the first week of April. And interesting, we went from 0 to 100 in 4 weeks. And it has taken probably 8 weeks to decant some of these patients. As I'm talking, I was looking this morning at the stats. We still have 190 COVID positive patients in this hospital, with about 50 in the ICUs. Remember that the peak again was about 500 with 230. So we have come down, and it feels much easier now, but I have to tell you that we're still far away from being in below 100 or even below 50 COVID positive patients.
Sounds like an incredibly formidable task, which you clearly met head on and did a great job managing it. You mentioned testing of employees. Is that testing of all healthcare workers at all campuses? And if so, how often are people tested?
Yeah, we debated a long time. And first of all, because of legal reasons, it is only voluntary. And therefore, you cannot really impose to test every single healthcare provider. Most healthcare providers have been tested. Most healthcare providers have been tested again. At this point, it's not only the nasal swab with a PCR, but it's also the antibodies, the serology with the antibodies. And then obviously there are concentric circles of healthcare providers. One thing is to be an intensivist, one thing is to be an anesthesiologist, one thing is to be a surgeon. One thing is to be a security guard. They're equally affected, or someone who delivers food to the different. So we have concentric circles of individuals at higher and lower risk of being contaminated and infected by COVID. But everybody on a voluntary basis can be tested. I have to say that we now have some numbers that are interesting. For instance, of patients admitted to the hospital with COVID-like symptoms, only 30 to 35% of them really have been positive with the nasal swab PCR. By the same token of the asymptomatic healthcare providers, only 1 to 2% turn out to be positive on a swab. And you can imagine that. So now we're learning more and more about this virus and the penetrance of this virus in different groups of individuals.
Thank you for sharing that very interesting information with us. I'd like to ask you a little bit about some of the changes that came about with COVID-19, particularly regarding telehealth for patients, and then telemedicine or visual and audio connectivity for us, whether it's Zoom as we're using today or some other platform for education. You're obviously training residents and medical students on site. You're taking care of patients as a referral hospital, but also as an Upper East Side neighborhood hospital. And you participate actively in numerous national and international societies. So which of these changes do you think are going to be, at least for the foreseeable future, quote unquote, permanent?
Yeah, I think that there will be a much higher penetrance of telemedicine and teleeducation. Let's put it this way. Teleeducation, we now do all our conferences, all our grand rounds, M&Ms, and so forth with teleeducation. The moment that there will be a vaccine, the moment there will be we'll be able to congregate again, I think that there will not be 100%. I think that, in my opinion, being together, discussing complications at M&M is probably better in person than through teleconnection. I think, on the other hand, that grand rounds sometimes can be easily done this way, avoiding sometimes traveling from coast to coast just for a 24-hour visit at an institution. There is a lot that nevertheless we need to understand that visiting an institution, whether it is you are the visiting professor or for the matter a candidate looking for a general surgery spot or a fellowship like we'll do this year, not being able to visit really, I think, has some detracting point. We just came through interviewing for 2 fellowships recently. One is the endocrine surgical fellowship. One is the GI minimal invasive surgery fellowship that we have. And I asked every single candidate how they felt about it. And they said to me, this is great. I'm not spending money. I'm not spending a lot of time traveling here and there. But unfortunately, I cannot see the place as well. So we need to be more creative in creating probably visits, virtual visits of our places, of our operating rooms, our ICUs, our simulation laboratories, etc., to be able to give an appropriate idea of our places. In the future, I don't know how many of these things will be virtual, how much will go back to visiting personally, and so forth. In terms of medicine, there is no question that patients love the convenience of calling in from their home. They don't have to invest their time in coming to the hospital, paying for the parking, waiting in the waiting room, etc., etc., etc. They feel an immediate connection with the with the surgeons, with the physician. I think there are challenges. The challenges is for us how to teach our residents and our medical students how to interact with patients, how to allow our residents and medical students to interview patients before maybe we talk to them or simultaneously. That's a challenge. The other challenge is for us, for disciplines where a lot can be obtained by an appropriate history and by imaging. I think that a telehealth contact may be quite sufficient in at least deciding whether the patient requires surgery or not, what is the next step. And the next step could be come and see me personally, by the way. But for interaction where a physical examination is essential, it's very difficult to think that telemedicine could really take the place of a real visit. So I actually think that different physicians, different practices, different surgical practice, it will have a different penetrance in using or not telemedicine. Most of us have been accustomed to do that, especially for consults coming from far away, from other states, or even from abroad. First interview was a telemedicine consult, and I think that it certainly has the ability to for sure have a first contact and take it from there.
Thank you very much, Dr. Michelassi. It's very enlightening. We really appreciate your sharing your thoughts with us. You certainly have, if not the most, certainly amongst the most extensive, in-depth, intensive experience with COVID-19. I commend you for what you've done. And on a personal level, I'm really happy to see you, even if only on video, see you in fine feather. Looking forward to getting together in person at some point in the future, who knows when we're all allowed to travel again and life resumes. For the meantime, stay well, and we appreciate your time and insights.
Thank you very much for having me. It's a pleasure to participate to these interviews. Thank you.